You know, it's relatively new.
Very easy, very comfortable.
Welcome to the next episode of Endoscopy Essentials. We have a very specific and very difficult topic today, and I'm so happy to have the world championship in this area, Takao Itoi from Tokyo. Welcome.
Thank you so much. I'm very honored to be here. I have seen a lot of your video, and so I'm very happy to be here. Okay.
Thank you.
You are. So today's my talk is my way of EUS-guided hepatico-gastrostomy. Recently, the EUS biliary drainage is very popular, getting popular and popular.
Yes,
so
yes.
I'd like to show my way.
A few questions. I think, you know, it's relatively new, but it's still a very difficult procedure. You know, ERCP, you have the duodenum. You can't move so much. Here you have the big stomach. You have to find your way. You have a moving organ and you have the liver, which is stable. So I think it's still one of the most tough procedures, right, in interventional endoscopy. But since you are the world champion, we are very keen to learn from you. So yeah, maybe we follow your presentation and I can interrupt you with some questions.
Yeah.
Good.
Okay.
Let's go.
Yeah, thank you so much. Exactly so. As you mentioned, the pancreatic biliary endoscopy is getting difficult. So basically, I loved ERCP first, but so failed ERCP case, so make it difficult to manage the patient management. So that's why interventional EUS one of option. As one of options, so I'd like to introduce or I'd like to show our procedure.
Mm-hmm.
Okay, let's get started. My way of EUS-guided hepatico-gastrostomy. As I mentioned, EUS-guided biliary drainage is getting popular, and nowadays EUS-BD is divided into three types. One is EUS-guided choledochoduodenostomy, and EUS-guided hepatico-gastrostomy, and lastly the EUS-guided antegrade stenting. Recently, the antegrade stenting plus hepatico-gastrostomy, we named hepatico-gastroenterostomy, the HGS. So recently we called that. And so today, EUS-guided hepatico-gastrostomy, I'd like to explain.
But let's go back maybe for 1 second. So there are actually two different approaches. One is directly into the common bile duct, which only works in distal strictures, right?
Yeah.
And you are still doing it for distal strictures.
Yeah.
But the left side, you go maybe instead of a left-sided percutaneous drainage, right? So this is the main competitor. And for those people doing PTCD by themselves, like our group, I think the left-sided PTCD is also quite difficult at times. So I think for the patient, it's much better to have an internal drainage, right?
Right.
Yeah. So let's focus on this difficult procedure from the left side.
Yeah. Thank you so much. Okay, so I'd like to say the indication of this EUS-guided biliary drainage. Basically, the failed ERCP case is mandatory. Firstly, the first line of this pancreatic biliary endoscopy is still ERCP. And of course, one of cause of this EUS-BD, the indication is a failure of biliary cannulation, transpapillary biliary cannulation. And so the other is the scope doesn't reach the papilla, cases. Of course, mainly the gastric outlet obstruction cases. The other is anastomotic, surgically altered anatomy cases. We cannot reach the papillary anastomotic site. At that time, so EUS-BD is maybe one of option or useful for the patient treatment. Yeah.
Again, there are probably two different aims. If you reach the papilla but fail, then you probably go for something like a rendezvous, is that correct? And if you can't reach the papilla, you have to reckon with a connection, right? To make it a permanent or whatever drainage. So these, you have to decide from the very beginning, right? What your aim is.
Yeah.
Okay.
Thank you so much. So exactly, so you mentioned the rendezvous is one of option. So in normal anatomy, I'd like to do rendezvous technique, but mostly the indication of this procedure is the gastric outlet obstruction cases. That's why rendezvous is impossible, not possible cannot reach the papilla. That's why just transpapillary, not transpapillary, transmural drainage is much better. Okay, so that's why as I mentioned again, the good indication of this procedure is gastric outlet obstruction or surgical altered anatomy cases. Okay, so there are several steps of EUS-guided, in particular EUS-guided hepatic gastrostomy technique. You can see the slides, puncture and the guidewire insertion, negotiation, and the tract dilation. After that, finally, we can place a stent. That's why we have to think about the 4 steps in each step.
But even before, I think you have to find the right bile duct. And that's, I think, where beginners have the most difficulty. So I go in with my scope, I see the left liver, but I'm sure you will have some examples to show us how to identify the bile duct and then puncture.
Yeah.
Step number 1. So here we have the 4 steps, which we might deal with in different podcast episodes.
Exactly. It is very important before the puncturing. In order to the puncture, we have to see the appropriate bile duct. In particular, in terms of hepatic gastrostomy, we have to see a dilated bile duct, B2 or B3, or which bile duct is appropriate to puncture. So that's why. For the beginner, I guess very difficult to find the appropriate puncture bile duct. That's why we at that time we always teach them to trace bile duct, intrahepatic bile duct from the peripheral to the hilar portion. Rotation and clockwise rotation, and which bile duct is better to puncture.
And you have to use Doppler probably to select out all the vessels?
Of course.
Which the experienced examiner knows maybe, but Doppler might be helpful, right?
Yeah, very helpful. If difficult to find, differentiate vessel and bile duct, in Europe, maybe like Japan, you can use contrast, enhance the agent, and easily differentiate. Of course, if difficult, mostly it's no problem, just a Doppler mode on, so you can differentiate, distinguish.
But sometimes you need the contrast if it's really difficult.
Yeah.
That's a very good tip. Yeah, okay.
Yeah.
And the position in the stomach?
Yes.
Do you have many choices, or it's usually proximal, huh?
Yes.
So in the proximal half of the stomach?
Yeah.
Where you end. Do you use X-ray?
X-ray,
initially
of course.
to determine the position, or you just go by EUS?
Both is very important. And so firstly, the patient position is a prone position. Somehow endoscopists prefer the spine position, but I like prone position.
Prone position.
Yeah.
And general anesthesia?
No. Just a conscious sedation, in the endoscopic room. So in Japan, very difficult to know the examination anesthesiologist. Yeah.
Well, I think if you have the option, and it's going to be a difficult case, which might take longer, I think the help of an anesthesiologist is a very useful thing. I know it's different, or it's variably difficult in different countries. In some countries, it's almost impossible. But if you have access to general anesthesia, I think you should think about, right?
Right. I hope so, and even in Japan. So when I go to the foreign country for the live demonstration, almost always, the anesthesia.
Yeah.
Very easy, very comfortable.
Yes, absolutely.
Yeah.
So maybe in live demonstration they use it more often, but I really can recommend it to try to get it in daily practice as well.
Yeah.
Okay, good.
Okay, so let's go the tips and trick my EUS-HGS. First, needle selection and puncture site. I guess most important thing, this number one. So what kind of needle is better? I think minimum friction between the needle and the guide wire. Sometimes the kinking easily happen, and so guide wire sealing or cut is very miserable or not good for the patient. And so one option is a large cutting surface needle. It's much better.
Which diameter are you working with?
19 gauge and
Always.
22 gauge both is very important.
But the guide wire is then adapted,
Yes,
right?
yes.
If you use a 19, you can take a bigger guide wire.
Yeah.
What is your preference, or does it depend on the size of the bile duct?
So later we will talk, and so if possible, so 2 millimeter in diameter, more than 2 millimeter in diameter, 19 gauge needle, and 0.25 inch guide wire, and less than 2 millimeter, 22 gauge.
Which is very small anyway.
Very small.
Okay, good.
And so not only the friction, but also the flexible scissor is also very important, because it's to make a scope angulation. That's why the flexible scissor, like a coring scissor, like this needle, they're very easy to make acute angulation. So to do acute angulation puncture.
So not necessarily if you have a needle for puncture, like FNA, FNB, it may not be the same needle you use for this intervention, because it has different characteristics.
Yeah, so if possible, so I want to use a dedicated intervention EUS needle, but so far nothing. That's why, so no choice. Just use common the EUS FNA needle. But recently, interestingly, some endoscopists, Japanese some endoscopists use FNA B needle. Why they use FNA B needle, the relatively large tract puncture hole, so can make it possible to make a good hole, and so without no friction. That's why but I don't like sometimes very dangerous to the best surrounding area.
They're more aggressive.
Exactly.
Because they want to get a bigger piece.
Exactly.
Yeah. Okay.
Yeah.
So it's a balance, huh?
Yeah, balance. Yeah. But so recent popular so needle is FNB needle in Japan, and others, not only the needle, but also the recent scope is EUS scope is very important. This is a brand new EUS scope, and you know the this scope can make a very good scope angulation, and if we use the elevator, more acute angulation, almost perpendicular. So we can do that, so we can target many area of the bile duct.
So the conclusion is you need a EUS scope with a large enough channel, a flexible tip,
Yes.
and a good angulation.
Right.
And the better, the better.
Better and better.
Yeah. Okay.
Yeah.
Oh, I see. Okay.
So as I talk, so when we use a 22 gauge needle, so relatively, Japanese endoscopist labs the 22 gauge needle in case of the non-dilated bile duct.
Mm-hmm.
So how dilate? So I'd like to show our paper. When we use a 22 gauge needle, the average bile duct diameter is 2.9. And the 19 gauge needle 4.4. Based on our results outcome, so now our strategy, we use 22 gauge needle for the less than 2 millimeter in diameter bile duct. And in contrast, we use a 19 gauge needle more than 2 millimeter in diameter. Maybe it's a good strategy. Yeah.
When you look at your cases, is it 50-50 or do you have more smaller bile ducts?
More smaller bile ducts.
So 2/3,
Yeah,
something
yes,
like that.
yeah,
Okay.
yeah.
So more difficult cases.
Yeah, exactly.
Mm-hmm.
In particular, you know, the obstructive jaundice cases usually is more than 2 millimeter in diameter. The malignant diseases mostly, but in case of the stone cases, surgical rotary anatomy stone cases, usually the interhepatic bile duct is not
so big.
so that's why in such cases almost 22 gauge needle first.
Okay.
Yeah. So always the beginner ask me that B2 or B3 puncture is much better. Either is okay for me. So many years ago, we love the B3 because we're worried about the transesophageal puncture. So looking at the B2 puncture, but so recently we realized very nice guide wire manipulation because of the minimum distort B2 to the CBD common bile duct. The guide wire manipulation is very easy.
So we're talking about segment 2 and segment 3?
Segment 2.
Yeah,
B2
2 versus segment 3?
Yes.
Can you always see on EUS which one you have?
Yeah, always can distinguish.
Okay.
Yeah. In particular, from the peripheral portion, so we can easily B2 or B3.
Mm-hmm.
Yeah. So always we teach junior doctor to trace from the peripheral bile duct to hilar portion.
And then back.
Yeah, and back and B2, B3, which one is better?
And the basic tricks are, where is D2 and where is D3?
Basically,
you go down, you find one.
Yeah.
And then you trace it to the hilum.
Yeah.
And look for the other one.
Yeah.
And then you trace it back.
Yeah, trace back.
Uh-huh.
Yeah.
And the upper one is which?
B2.
Okay.
Yeah.
Good.
Yeah. So the B3 is looks safe, but
because it's deeper.
Yeah, exactly. And sometimes the scope going down and up angulation a lot, and easily if we puncture and or delivery system advance at that time, so easily back towards the gastric wall, the back to the gastric side. Easily. That's why. So a very smooth straight scope position is a B2 more. Yeah.
Well, maybe an advice for beginners is that if you want to start this, maybe in your diagnostic EUS,
Yeah.
you look for D2 versus D3. Even if you deal with the pancreas and it's not in the focus, but you can train that in every diagnostic EUS, right?
I totally agree
Yeah.
with you. Yeah, it's the first step of the
Yeah.
EUS-HGS.
So
Right.
don't train with the first puncture case, train before.
Right.
Okay,
I
good.
totally agree.
Good.
Okay, so let's go the actual puncture. So we have to take care of the intervening blood vessel. As I told you, the vessel is very close to the bile duct. That's why. So like thread cases, we have to take care above the bile duct vessel, mostly the portal brain, and the B2, B3 either. And more than such careful or such caution, intramural, intragastric vessel is more caution is needed, because mostly the tip of the echoendoscope compress the gastric wall.
You don't see it.
Yeah, at that time, so non-intentionally, but easily disappear. It's compressed and disappears the vessel, even the artery. But down angle, so we can see easily.
You should release it
Exactly.
and see.
Exactly.
Okay.
Yeah.
So you have two enemies. One is in the gastric wall and the other one is in the liver. Two vascular enemies.
Yes. Yeah.
Okay.
Yeah.
Also a good point.
Yes.
You could also train this before.
Yes.
Yeah, look for bile duct, for vessels, and before you start.
Yeah. Exactly.
Okay.
Yeah.
Good.
And so next, caution is transesophageal punctures. You know, in particular B2 is very close to EG junction. That's why. So we always take care of the transesophageal puncture.
Is it forbidden? Should you avoid it? Yes. Huh?
Should be avoided. Should be avoided.
So you always, when you have a nice position, which is a little bit like 30 or 35, 40 centimeters, you always check endoscopically.
Yeah.
And then may abandon and go somewhere else.
Yes.
It's also an important message.
Yeah,
you have your EUS image all the time.
Yeah.
And you should ask yourself, wait a bit, am I in the esophagus? And then you check and say, oh, I'm in the esophagus, and go down, right?
Right.
Okay.
So let's see a video next.
Yeah.
So this is before the puncture. You can see. So please see endoscopic imaging. So puncture site let contact mucosa, and so back, and we can see EG junction.
Back and back. And
yeah. Down angle and back, and pushing and up angle. So this is a safe area below the EG junction. That's why. So maybe non-transesophageal puncture from here. It is also very important.
So there's always a double check with endoscopy.
Double check. Yeah.
Okay. Good. So I think we have learned a lot about positioning, and if we conclude this episode, there are some messages. So do some training before. Before you start this, not train the anatomy on the first hepaticogastrostomy case. That's a mistake. So get familiar with the anatomy and take care that you are not ending up in the esophagus. Yeah, we have talked about needles, etc. And in the next episode, we will go one step further. Thanks very much for this one.
Thank you.